All right. Well, hello and welcome to our final program of Technology Association of Oregon's Digital Health Week. Thank you to everyone who has joined our conversations throughout the week. We're excited to round out our programming with a conversation focused on innovative healthcare delivery and broadband network infrastructure. I'm Skip Newberry, President and CEO of TAO, and I'm joined by Riley O'Brien, who's the VP of Events and Experiences, who's going to be providing back-end support via Zoom. A couple of rules of engagement before we start. Participants have been muted, so please remain on mute unless a TAO staff member unmutes you and calls on you to talk. You may ask or respond to questions in the chat box publicly or privately by directing your message to me or Riley under the name Special Events. We're going to monitor the chat box and respond throughout the discussion. We'll ask you all to engage via the participant icon on your screen, and please engage with us on social media during this call and throughout the day. We definitely love to share what's happening at TAO and to get participant takeaways from our events. A huge thank you to Link Oregon, Otradi, OBI, HIMSS, the Israel Consulate General to the Pacific Northwest, OCHIN as well for underwriting Digital Health Week. We appreciate your support and are excited to explore topics related to digital health. Finally, it's my pleasure to introduce the panelists for this conversation. We have Catherine Britton, who's the Executive Director at the Telehealth Alliance of Oregon, Miles Allenby, who's the Professor of Pediatric Critical Care Medicine and Medical Director at OHSU, Office of Digital Health. And then finally, last but not least, Steve Corbato, who's the Executive Director at Link Oregon. So welcome, panelists. Wanted to have each of the panelists take a moment just to introduce themselves and say a few words about their respective organizations, and going in really no particular order here other than this is the order in which they appear on my screen. Wanted to start with Catherine, and then we'll go to Miles, and then finally Steve. Catherine, the floor is yours.
Thank you, Skip. As Skip said, I am the Executive Director of the Telehealth Alliance of Oregon. And when I got this invitation, I had to laugh because it's sort of like cow meets Tao. We both have the same initials, and very often when people conduct a Google search, they'll call me and they'll go, "Why did I get this technology association? What is that?" You know, and so it's kind of I guess a meant to be sort of situation. I've been involved in telehealth since 1993. Which makes me one of the more mature telehealth people in the United States. And I got started with what was called the Governor's Coordinating Council, which worked to put in place some basic structure around technology or telecommunications technology in Oregon. And there were a group of us on that council that were really interested in telehealth. And so we ended up breaking away in 2005 and forming the Telehealth Alliance. And we've been going ever since. My passion is telehealth because during that time that we were working initially, my mother was one of those people whose life was either cut short or really diminished by her lack of access to care. She lived in Eastern Oregon, and her provider lived in Spokane, and the only way that she could see him was a fixed-wing aircraft or a helicopter. And so as I got started in this business, this meant a lot to me because I firmly believe that my mother would not have had the end-of-life experience that she had we had access to broadband services at that time. So I also serve on the Northwest Regional Telehealth Resource Center Board, and we work in collaboration with 7 states to make sure that we provide the resources that folks in healthcare need to develop telehealth programs and manage the policy. So I'm just thrilled to be here. Thank you.
Excellent. Thank you, Catherine. You know, it's funny when we were deciding between the Technology Association of Oregon and the Oregon Technology Association, it was either OTA or TAO. So there's either the Telehealth Alliance of Oregon or the Oregon Truckers Association, and we had to pick one or the other. So next up we have Miles.
Miles, you're on mute.
Miles, you're on mute.
Can you hear me?
Yes. There we go.
Okay. Okay. Sorry, I think we were vibrating back and forth there. Hello, everyone. My name is Miles Allenby. I kind of call myself a reformed engineer. My background was in engineering before I went into medicine. And I've always been looking for how to apply technology in healthcare. My clinical role, I've been at OHSU now for 20 years, and clinically I'm a pediatric ICU doctor. And early on, we realized that we were doing a poor job of triaging patients over the phone for transport up to Portland. And that was really the origin of our telehealth program at OHSU in the aughts. In 2007, we started a pilot there and recognized the value of being able to see patients over video. Since then, our program has grown significantly. I now serve as the medical director for the entire university's telehealth services, recently rebranded as the Office of Digital Health, recognizing that telemedicine, telehealth definitions are a little bit more limited than the term digital health, which seems to be taking off. Additionally, I've been able to serve on the state's Broadband Advisory Council for the past 11 years, trying to, again, match access to our patients. I appreciate the opportunity to talk with you all today, sharing our experiences, taking what was a growing program and then the exponential growth that we saw this past spring with the onset of COVID. Just as a brief example, we had historically been offering about 1% of all our outpatient services digitally, and that ramped up to 70% in about 3 weeks' time. Some of that was due to regulatory relaxation, and a lot of it was based just on need. And as some of the restrictions and people feel more comfortable coming back to the hospital have lessened, this volume has settled down to about 30–35% of all visits are still happening digitally. And it's something that both our patients and providers are now realizing the promise that we have long proposed, that a significant amount of healthcare can be delivered virtually, either synchronously or asynchronously. And we really think that there's no going back. Seema Verma, who's the director of CMS, stated that the genie's out of the bottle. And so I'm looking forward to talking more about where we see this all going in the future. Thanks.
Excellent. And Steve, calling in from Southern California.
Virtually. I'm adhering with the governor's travel quarantine as well as the latest CDC recommendation. Which was pretty surprising today to see this. Thanksgiving is now canceled. I'm executive director of a relatively new nonprofit in Wink, Oregon, and we are a partnership of the 4 research universities and state government. And essentially, the 5 largest public entities in the state got together with the idea of combining our forces and really expanding the capabilities of a middle mile network statewide. And now we go from Ontario to Pendleton to Portland down to Newport and Ashland. We've got more to go, but we've had a very significant build out this year. Our view is our mission is our members' missions. We have the 4 research universities, so education, research, public service, and healthcare. And healthcare touches our members in different ways through the Oregon Health Authority, through OHSU directly, but also programs, pharmacy at OSU and public health at PSU. So we have a strong interest. We recognize that we serve as an anchor tenant in rural communities. And essentially by aggregating public demand, we can partner with the broadband providers in those communities in different ways. And quite frankly, we will work only with those that are actually investing in their communities, and also try to advance best practices. I've been fortunate enough in my career to have been around these efforts both in Washington State and Utah. Washington State about 25 years ago, and in Utah about 10 years ago. So I think we can learn from what other states have done, but we have the advantage of really trying to build out now when the need is most evident.
Excellent. And wanted to start with the moderated questions, I think with Catherine. So I was wondering, how do we make healthcare services more easily accessible and affordable? There we go.
Okay. I think that the responsibility for making this happen lies both with the technology community as well as with the healthcare community. There are things on both sides that are blocking easy access and also blocking affordable access. I think, first of all, what we learned with COVID is that we need to provide care to patients where they are. They are not going to travel long distances if they don't have a car, if they don't have time off work, if they don't have gas money, all of those sorts of things. They can't travel if they're elderly. And avoidance of healthcare will raise the cost of healthcare. So we need to look at making sure that insofar as possible, we are providing care to patients in the setting that they wish to receive it in. We need to look at the various disparities that we are dealing with that are particularly pronounced during the pandemic. We need to look at how do we provide care to people in very rural areas, and we're looking at needing some help from broadband to make that happen, but also realizing that broadband's not going to provide an immediate or even a short-term solution to some of the areas that we have patients that need services. And so it becomes healthcare's responsibility to figure out a solution that we can use that will help remove some of the difficulties for those folks trying to access care. One of the big ones is that during the time of COVID, the CMS and the state relaxed the regulations against the use of the telephone. We are now sitting at a precarious time that when the PHE ends, that relaxation could go away. And if it does, so does the care for a lot of people who do not have access to broadband and who probably are not going to have access to broadband in the near future. So that's one of the things that we could use support from both sides. We need the data from healthcare to show that we can successfully provide services to folks. And we need the support of telecommunications to look at how we can better distribute even dial-up access and maybe expand dial-up access so that folks can continue to receive their care in that way. I think it's especially important for people who have mental health and behavioral health issues, because very often this is the only way we're going to get to folks who have need of those services. I think other disparities arise with folks who may live in an area that's served by broadband but do not have the funding to purchase the service from the broadband provider. They don't have the funding to purchase the telehealth devices that are needed in their homes to do remote patient monitoring or to be able to communicate in a face-to-face visit with their healthcare provider. I think that the other big issue in terms of access and care has to do with funding for providers by Medicare. And one of the things that we do is we struggle mightily to get changes to Medicare that allow us to serve our elderly populations and to pay for those services equitably with our healthcare providers. So I think those are three of my biggest concerns. And Miles, please chime in with what you have from a clinical perspective.
Well, I was going to agree. I agree with all those comments, and I'm sure this is probably not the first time you've heard this comment this week, but really moving to a mindset where broadband is considered a utility, a basic utility, much like water and electricity, is really the mindset we need to work with going forward. There's so many things that are dependent on it these days, commerce, education, healthcare, that I really don't think we can go back. And then another thing I used to say prior to COVID was that, we're trying to practice 21st century medicine with 20th century regulations where people couldn't imagine this type of access. And now we really need to make a lot of these relaxations permanent. So we really hope that can happen. And finally, also, I would add the recognition that not everything needs to be delivered over high-speed video. There's a lot of care delivery that we are now undertaking that's happening asynchronously, lower bandwidth needs, texting, asynchronous communication, which again is not perfect for every scenario, but it often serves a lot of needs. And on the healthcare side, recognizing and figuring out which platforms are necessary for different clinical scenarios. As Kathy mentioned, telephone is often adequate. Video is better, but we need to kind of sort all that out.
And Miles, just following on that, you mentioned, at least one example of like a COVID-related learning, and I'm wondering if there are others that would be worthwhile sharing in terms of how we actually improve sort of more longer-term fixes to our healthcare delivery systems with any sort of takeaways that you've noticed so far during the COVID crisis.
Well, I don't think I'd be the first to say this, that healthcare is often very stagnant with embracing new technology and new modalities of delivery. And this has really forced providers to really look at things in a different way. And so I think there is now greater recognition that there's a lot of different ways to get to our patients. So I think that will help things. I think Seema Verma from CMS was famously quoted this past year saying that the genie's out of the bottle. Now that we've unleashed all this, people are recognizing the value. And we've a lot of our volume increase has been around ambulatory care, but we're also recognizing that all levels through the care continuum are affected by ability to deliver care visually. From the extreme examples of virtual ICUs, where there's not enough intensivists around the country, even before COVID, to take care of all the patients in hospital, even exacerbated now by healthcare shortages and fatigue, to be honest, that many ICUs are now being staffed remotely by virtualists, and that's one platform. And then back to the home, as Kathy mentioned, platforms like remote patient monitoring, where those with chronic disease can live more comfortably remotely by knowing that every day they're connecting with their provider asynchronously, but providing data to facilitate their care. And it's a bit of a time of reckoning and recognition that the old way of doing business is not necessarily most efficient or patient friendly.
I think a couple of other learnings that we've had are one, that we have a tremendous gap for some of our folks, not just our patients, but our providers. Am I still? No.
Good.
I'm sorry, I'm paranoid here. With digital literacy, we have been dealing with folks who have never experienced dealing with technical or technology in their homes in this way, and they struggle just to be able to connect, let alone to perform the functions that they're sometimes asked to. We also, our learnings show us that we've got people that have hearing loss. We have people that have dementia. We have people that have language barriers that we need to figure out how to provide them with some literacy training so that they can really get the full benefit of what telehealth can provide for them. I think the second big learning that we had was that providers were not only not literate, but didn't want to be literate. And so we ran into the instances where providers that we could have used to provide telehealth just said, no, I'm not going to be a part of this, or digital health. I'm not going to be a part of this. I don't want to be a part of this, and I'm not going to learn. And so that's created a quandary. And which points then back to the need to educate our healthcare students, whether they be physicians, whether they be nurses, whether they be even folks that are supportive in terms of community health workers and things like that. They need that training on digital literacy in order to be able to function effectively in the environment that we'd like to create.
That's definitely well said, Catherine. Steve, I'm wondering, both Miles and Catherine have shared a little bit about sort of what they've seen in the COVID environment. And I think one thing that COVID has really kind of highlighted for a lot of folks is the importance of infrastructure. And so in the healthcare space, I'm wondering, what needs to be done to make sure that connectivity options are sort of more adequate in supporting the efforts of the hospitals, the clinics, other service providers. I think Kathy mentioned meeting people where they are. Like, how is that enabled by infrastructure?
I think that's a really good question. And the thing that I can say is we're having this discussion about healthcare, but yesterday I was having this discussion with the Oregon Department of Education. And we've really shown that broadband is not just a social determinant of health, but also education, work, and really life. I think there are several things that we can do near term. First of which, Link Oregon's role is to be the middle mile network for essentially the provider organizations, the hospitals, healthcare clinics that are in the public and nonprofit space. I think as a state and as a country, we've got to look really hard at how we approach this. And the past approaches allowed essentially the problem to be papered over, and we had insufficient mapping data. And just as we saw with COVID in the spring, and not really knowing where the cases were, the first thing we need to do is have a better national mapping effort. There is an effort underway that's state-based. And I also think it should not just be based on provider input, but it should actually be crowdsourced by individuals going to websites and actually doing measurements off designated measurement servers. So some states are beginning to do that. We're certainly advocating for that here in Oregon. I'm not a politician, but I've been in DC about 100 times. Maybe that does make me a politician. But I would say that we have the clear sense that both the federal and perhaps the state government is going to make a major investment in closing this broadband gap. And one of the things I think is really important is essentially apply the Wayne Gretzky principle that we should skate to where the puck's going to be. And we have a broadband standard right now of 25 megabits per second down, 3 megabits per second up. It started in the policy process about 10 years ago. Until just recently, the rural standard was 10 megabits down, 1 megabit up. We should not make a backward-looking investment with that as a standard. I'll look to the north of the Columbia River and look at Washington State right now. They've adopted a goal of 150 megabits per second symmetric, equivalent up and down, by 2028. And I really the nice thing is one of the nice things coming out of the pandemic is that we now have a partnership with 4 other Western states, where the state broadband offices, the public networks like Link Oregon, and our state librarians are meeting regularly. And that's one of the common mapping and that what the real broadband standard should be. The other suggestion I would have here is I really think this problem is serious enough in Oregon that it's not going to be solved by one agency. We really need a whole of government approach and a task force. You start with the state broadband office, which has one of the hardest working state officials I've ever met, and Chris Cameron. Let's get Chris some support. I see that motion's been seconded. But then looking at other agencies, OHA, ODE, same boat as far as the recipients of those services being impacted. We have to pull in the state IT organization and particularly pull in ODOT. The state transportation department has the coin of the realm in our business, which is right of way and conduit. And I think as a state, we can do better. I was at the University of Utah. I was part of an effort where we worked with the equivalent State Department to make those assets available. And particularly when we're trying to get to rural communities, the best way is on highway right of way. So I think thinking strategically, this is a 5-year project. If we go really fast, but I guess now with the vaccine time scale, we're used to projects that aren't finished in 90 days.
Well said. I like the analogy at the end with the vaccines. I think, as we think about sort of the issue of equity, poverty, we know that sort of a lack of broadband access can lead to increases in poverty levels and lower opportunities. Steve, you mentioned education being one that's analogous, access to critical governmental services, healthcare, economic opportunity, the list goes on. So I'm wondering, what are your thoughts on this idea, specifically Miles and Catherine too? Like, what are some of the potential policies that could help address these gaps? I think Steve just kind of summarized a whole panoply of different federal and state and regional efforts. What are you all seeing, Catherine and Miles? And then we'll go back to Steve.
Well, as Catherine already mentioned, there were a lot of regulations at the policy level that really impaired our ability to deliver care to where the patients were. Medicare, Medicaid had restrictions on site of care, urban versus rural settings, and the definition of rural was a bit absurd, to be honest, based on metropolitan statistical area. So as an example, Lane County in Oregon, because Eugene is a large enough city, the entire county was considered urban, which obviously is absurd. Reimbursement, unfortunately, the reality is there needs to be reimbursement for work done. And so reimbursement reform is also critical. Kathy really helped lead an effort more than 10 years ago now to get the private payers to pay for telehealth services is the same as face-to-face, but the federal payers have been slow to come to that. So keeping those changes in place are going to be critical. And then it gets back to the individual level. Do they have broadband? Do they have a device? Do they have the literacy? I always call back to the Digital Inclusion Alliance, what's necessary. And so literacy is an issue, especially with an older population. And then if there's language issues, that's another significant issue. How can you get translator services involved with these connections? And then lastly, are we as providers creating the applications that are going to be of utility for people? But I am hopeful now that people have seen the benefits, and I don't think we can go back.
Right. Catherine?
Did it. I think there are a couple of other policy issues that we're going to need to deal with fairly quickly. First has to do with licensure of providers across state lines. And there is no right or wrong side. It's just such a difficult issue. We have tried in many instances to fix it by creating licensure compacts, and the COVID rules have certainly relaxed our ability to practice across state lines. But I think the more we tinker, the messier it gets, and it's very difficult to deal with all of the concerns that go with licensure of providers and balance that with the need to be able to have providers available in places where they're needed rather than in places where they're physically located. Very interested to see how the VA handles their universal licensure with their VA hospitals and their patients. I think the other one of the other issues is that there are a lot of rules, as Miles mentioned, that deservedly needed to be relaxed and need to stay relaxed. But I also think that there are some that we need to take a hard look at. And if we cannot provide the data for some of those relaxations, then we got no business advocating for keeping them. We need to look at what the true benefit is. And I think if we don't do that, then our credibility will be damaged in terms of getting Medicare and Congress to make further moves, and also at a state level towards removing some of these barriers. And finally, Miles mentioned the rural-urban thing. I just finally threw up my hands the other day and I said, I don't care. It doesn't matter. It shouldn't matter whether healthcare is delivered in a rural area or an urban area and that there should be different rules. It's ridiculous. And so I don't know how you create a rule that says there's no rural urban, but I would love to see a way to do that and make that kind of a universally accepted idea.
Catherine, you mentioned earlier, like there's definitely a clear demand for, services, health services in people's homes is made as easy as possible, like reaching people where they are. And I'm wondering, do you see some constraints on sort of the supply side? And what might those look like?
Yeah, we're already seeing constraints on the supply side for just with COVID. I mean, we certainly do not have the depth of providers that we need to manage COVID and to manage the rest of the healthcare issues that we have. And I think as we look at serving the homes, serving schools, which is providing healthcare in schools, is another issue that we are going to be facing, providing mental health and behavioral health services to folks. Just aside, if we think that the COVID pandemic is bad, wait till the full blast of the mental health pandemic hits us. We are going to be so overrun and fraught with the need to care for not only the general population, but I think our healthcare population is going to be severely in need of mental health services. Somebody said, well, veterans by far have the biggest mental health needs, and I wanted to say, no, wait till you see what the healthcare workers who have worked on the front lines of this pandemic encounter and have need for. So I think that those are going to be some really serious issues. One of the problems I think that we face is that we have trouble allowing our non-physician providers to practice at the top of their license. We feel the need to supervise them, to somehow manage what they can and can't do after we already trained them to do those things. And I think we need to take a hard look at how we allow our non-physician providers to practice and to help relieve some of the difficulties we have in meeting the need. I think we need to look at community health workers. Not that they need to provide licensed services, but they certainly can be a service for folks when we're dealing with disparities of food insecurity, housing insecurity, those sorts of things. I think that we need to look to people who are well trained and capable of providing services and allowing them to do that.
Miles, do you have any comments there in terms of like, where you see potential supply side issues?
Well, the minute you asked that question, I thought similarly to Kathy, is that it's not just physicians that provide healthcare. And so there are a lot of other providers that can take advantage of these tools and get to the patients where they are. So I'd agree there. And we always, we've learned in medical training for decades now, and there's recognition about the social determinants of health. And what we have also learned with telehealth expansion with COVID is the people that have poor social determinants for health also have some determinants for access to broadband and access to devices. So where we thought telehealth was just going to be this great be all for improving access to care, certainly has helped. It still raises those same disparities and inequities anyway.
Well, related, Miles, but like what are some of the types of care specifically that are most like impacted by a lack of broadband or connectivity?
Well, simple telephone video visits, for routine care, follow-up care for a lot of procedures. Before COVID, I used to always describe the scenario where you have a surgery at one of the big hospitals and you return to your rural home. You are then expected in 2, 3, 4 weeks time to return to the surgeon for a wound check. And that's a quick look and okay, great. And you're spending a day traveling, loss of work and so forth for something that could easily be triaged over video. And there's a number of other scenarios where you travel great distances for very short visits. And I've always highlighted the power of video to triage. And really, and there's clinicians that have oversubscribed clinics. They can't get new patients in. They have 2, 3, 4 month waiting lists. But the patients they're seeing day by day, many of them don't actually need to be seen in person. And so if we could do a better job of triaging, so there's a number of different modalities that have now been created. An example is something called the e-consult, where a primary care provider, instead of sending their patient to the specialist, the cardiologist, for example, instead will send a question to the cardiologist with some records and some information and ask for next steps. The next step does not necessarily need to be an in-person visit, and that the primary care provider in the community can often get things started and often get people well on their way. That is now a reimbursable activity. So the consultants will be willing to do that work. It's more efficient for them and it frees up their spots. If I'm a gastroenterologist, I really don't want to see a clinic full, well, I'm in pediatrics, I want to see a clinic full of kids with constipation where I could get them started on their way before having to suck up at one of my very valuable clinic appointments. So I think that's the power that some of these platforms allow.
Excellent. And, Steve, I have a bunch of questions I want to kind of like throw your direction, but it sounds like you might have some additional comments.
Yeah, I was just going to say something as the person that's most directly removed from the telehealth delivery, more focused on the pipes. We had a moment about 2 months ago where the person for the Oregon Health Authority, who's responsible for COVID-19 suicide prevention, came. And she got the attention of our board for about 15 minutes. And I think there's a real sense of people that work in our space right now. And it's not just due to COVID, but also wildfire response after this fall, that things are different and that there's a greater social responsibility. The other thought I have here is I'm a great believer in going back and learning from mistakes and successes. I wonder how much of what we're trying to do with broadband was faced by the people trying to do rural electrification and to push electricity out into the more difficult places and cities in the 1920s and 30s. And yes, the socioeconomic fabric is different now, but there were some economic incentives put forward, as well as a large stimulus package through the New Deal that I think we can learn from.
Steve, one thing I was thinking about was hearing you talk about some of the state and regional and federal efforts underway. I know just in the last, I'd say 6 months, probably 9 months since the onset of the COVID crisis, I've never seen such a coalescence around sort of what the key priorities are is determined by the state, by public sector, private sector, academic, right? It's things like access to learning, access to healthcare, access to economic opportunities and training related to that. And all of it is dependent on broadband and connectivity, right? And especially in this environment. And I'm wondering, what are some of the, where do you see the greatest momentum right now? You've mentioned state, you've mentioned federal, you've mentioned some local grassroots efforts. The tech industry is trying to figure out where, with its influence, can it have the biggest impact in the state? Talking with Betsy Johnson, Senator Betsy Johnson, just yesterday, she was like, broadband and connectivity is low-hanging fruit because it makes tech less esoteric. It impacts every Oregonian.
Right. Yeah, and eventually a tech, tech may be esoteric at some point, but a smartphone was considered a novelty 15 years ago, but now you've got to have it. I think you probably need to think about this problem differently at 3 different levels: localities, state, and federal, and maybe I'd stick in region as well. I think the last few years have taught us that the federal government isn't coming to rescue us, and that particularly in the West, we've got a set of states that are now pretty much thinking alike, and we may advance ahead of the federal government in terms of broadband standards, and that will increase the attractiveness of our area for businesses and individuals. At the local level, I'll go back to that message. FEMA, there's not a broadband FEMA coming to rescue you. And as we've worked with Chris Tamron at say Broadband Office and also John Huffman at USDA Rural Development, we've stressed the point that these communities really need to organize. There's and form what I might call essentially a broadband collaborative group, an action team. Usually the K-12 is there, the healthcare institution, the 911 service, county commissioners who are involved who are concerned about the economic viability. I had a conversation with the county commissioner of Lake County, which is 2 hours east of Klamath Falls and really remote northern Great Basin territory. And there's an active fiber build underway through his community, but it's not clear there's going to be an access point. And I told him he needed to fight for that the way that communities in the West fought over railroad junctions in the second half of the 19th century. It's that, and not just junctions, but also right-of-ways. It really is essential to their viability. I think states need to be coordinating entities, especially for Oregon. We're a long way from DC, and nobody inside the Beltway understands the fine structure between Portland, Eugene, Klamath Falls, Bend, or Ontario. I think having statewide proposals, coordinated proposals, so we give them one option rather than they've got to pick between 20 options and they don't know the difference between Drain and Prineville. I think that, and at the federal government, I think there's an opportunity right now. There's going to be a change in administration. We might see another national broadband plan effort. I would look for the National Telecommunications and Information Administration in Commerce to play a greater role now, and I think they have more of a end user focus. I think historically over time, and I think that's cause for optimism there.
Well, one thing you just mentioned was, with Commerce, you've got NIST and NTIA, and a big focus on the part of those organizations is kind of avoiding balkanization. What are some emerging common standards that help accelerate or grease the skids when it comes to technology adoption and therefore the infrastructure in place that's critical for healthcare delivery? Where do things stand currently, and what more needs to be done?
So I'm going to recycle a suggestion I made for the state at the federal level. And there's actually an example that there has been an interagency task force around high performance computing, big data, that's operated I think the roots go back to legislation that Al Gore introduced in the 1990s. So that has all of government, the intelligence community, which is a big driver of tech, as well as agencies more focused on end users. I think it's going to take a similar effort at the federal level. And I think it would actually be good for the country. Let's focus on solving big problems rather than fighting over crumbs. And that, but agencies like the FCC, NTIA, USDA, which pumps a lot of money into rural communities. National Science Foundation has a role with innovation, and NIST has a key role on the standards front. So I think I think we can look for that. We can hope for it. But as I tell my staff on a daily basis, hope is not a strategy. And I think it's really important for localities, especially to have a plan, to have essentially have a proposal in hand when funding opportunities emerge, that they can jump on it, because the time to prepare those proposals now could be greatly reduced. And if you wait till the submission hits, or the call hits the street, you may be too late.
Catherine, in terms of interoperability and standards, I'm sure you've probably heard a whole litany of sort of issues along the way over the years. What are some of the things that are top of mind as you're seeing it from across your members?
Well, I think one of the difficulties is that we need to look at not, because a lot of people getting into telehealth look to the vendors to provide them with standards or information about standards and solutions. And equipment vendors are going to tell them what their needs are, and not what the healthcare providers actually need. And I think that's a difficulty that we run into. We find people with these horrendously big systems that they have absolutely little use for, and where that system is, it's in the closet because it's too big and too difficult to manage, and it doesn't meet the need. And so and we look to trying to encourage FDA to come up with the standards for equipment. They've been traditionally very, very slow at doing that, but taking a lesson from COVID, if they can pump out a vaccine approval, they can certainly pump out an approval for standards for equipment. I mean, it seems like a no-brainer to me, but then that's why I'm probably not employed by the FDA. I think that one of the difficulties we run into is that we don't understand each other's standards. We don't understand what education needs. Education doesn't understand what local government needs, and nobody understands what healthcare needs. And so I think we talked about 10, 15 years ago that we need to create community plans, but how we manage those plans is difficult. And I think even if we do manage to create a plan, and then we take it to some place like the FCC or USDA for funding, it ends up getting broken apart because the silo for healthcare funding comes here, and there's a silo for education funding, and there's a silo for government funding, and it all it seems like for naught. It seems very, very frustrating.
That's a really good point, Catherine. I mean, there's tons of resources across all these different agencies, all these different levels, and they're not necessarily deployed in a terribly coordinated way. I mean, Steve made the point about like NSF, NIST, NTIA, the list goes on. All of these, many of them have funding capabilities, and yet they're not necessarily aligned in what they're funding and how. Miles, what are your thoughts?
Well, I'm not sure I could add to what Steve and Catherine have said. There are there have been access problems before COVID, and this has only highlighted them. And so I hope there's some direction at a high level, at the federal level, to really, as I said earlier, broadband needs to be a utility. And I'm not a politician either, so I don't have much more to offer on that front. But, yeah. But it is going to be the future of education, economics, healthcare. I mean, on and on and on. And yeah, I mean, we know in medicine, siloing is bad for patient care. It's going to be the same for anything else that you look to. So.
Mm-hmm. So we've talked about a lot of topics today, including some of the sort of potential policy barriers, the potential bureaucratic inertia around this. I'm wondering, we also talked about supply side, right, barriers, but on the demand side, I'm wondering, are you all seeing some areas where, whether it's with a focus around security or concerns around security, or whether there's concerns around data privacy and what's happening to data, healthcare data as it's being transmitted? Are there any things there that you see as potential hurdles? And if so, potentially, are there examples of states or localities that are addressing this in a reasonable way? So I don't know, Catherine, do you want to start there? Oh, she's still on mute.
I thought I'd gotten over that. Security is certainly not my forte, but I do know that there are a lot of concerns on the part of our healthcare, our patients about their privacy and their security, but there are also some total blind spots. When we set somebody up for a telephone session, we have to tell them, this is not secure. You need to understand that this is not necessarily going to stay private. And I think they didn't even consider that at some point. And so so sorting out the real privacy and security issues from what people have kind of conjured up in their own thinking is sometimes difficult. I think providers struggle with knowing how to provide secure services. Particularly, Miles the engineer is going to go, yeah, that's not secure, or this is not going to be safe. But, Dr. Jones down in Jordan Valley is probably going to go, I don't understand this. I don't, how do I know that what I'm doing is secure? And they have a lot of people telling them, your electronic health records have a level of security, and your telehealth has a level of security, and your hospital itself has a level of security, and the standards have to all be met, and it's hard. So I'm part of the struggle. I'm not part of the solution, I guess. So.
Well, no, those are all great observations. It's essentially, like what are you hearing out there? And you've definitely shared exactly what we're hearing across a number of areas. It goes back to digital literacy. It's almost like we need a basic civics course in technology for Americans, because so much of what they have to deal with day to day impacts them through technology. So to understand and trust the technology requires that they have an understanding of the technology to trust it. Miles?
Well, one of the things I was going to say is, one of the relaxations with COVID was they allowed providers and patients to use any platform essentially that weren't HIPAA compliant. And another organization said, no, that, we're not willing to go that far. But I agree, on a populational level, there's a lack of understanding of what you're putting out there. Another thought I have is, as far as literacy, it's not just on the patient side, it's also the provider side. And
yep.
A number of providers were hesitant to go into this because they thought, it wasn't going to be as good, it's not safe, et cetera, et cetera. But they're more and more realizing that's not the case. Not all of them, but a number of them. But now in medical education, telehealth as a delivery methodology modality is being taught. So there should be greater literacy around that, hopefully going forward. We all know that the younger population is much more comfortable with this technology. Do they understand the implications of what they're putting out there? I doubt it.
Yes, right. No, and I think there's a great question posed in the chat as we get into Steve's thoughts on this. I mean, specifically, like what role might greater connectivity provide in solving, more of this sort of trust issue when it comes to greater transparency of people who are, receiving healthcare services. What are your thoughts there, and might it influence delivery, funding, privacy?
I think, essentially where we're headed is to have a much more instrumented world.
Mm-hmm.
You see that in education with analytics and with digital health, smartwatches and the like. I think this is all going to get tied together. I do think we need to think about the privacy aspects, and I don't think a privacy law, which is now over 20 years old, the last time I checked, is going to get us to the promised land, if you will. I think the innovations in Europe around privacy and also in California, we need to look at those. And I told my son at the beginning of the pandemic that two things were going to die during the pandemic. The first of which was Ayn Rand, and the other was HIPAA. And I don't know whether that was prophetic or not, but I do think we've seen a relaxation of privacy. Just the number of people through contact tracing, the number of disclosures of cases now. I see one a day, and we've never seen something like that before. So I think the societal awareness, the definition of privacy is changing, but also we need to think about what the impact of the loss of privacy is as well. To say something to the policy community, the policy community needs to get out in front of the technology for once, rather than being behind it, because the technology is moving fast.
Yep. Yeah, and I think that's a great sort of statement, if you will, given the state of affairs here in Oregon right now, heading into 2021 for that session. There's definitely talk about doing a contact tracing bill, and then 2021 or 2022, more of a comprehensive data privacy bill. And I think a lot of what we're seeing in sort of the telehealth space and in the education arena and remote work, all of those use cases present kind of more visibility to some of the data privacy implications of more distributed technology. To your point, it's more instrumented, and we're living in an increasingly instrumented world. So with that, I think we're about at the hour. So wanted to say thank you to our panelists for spending some time with us today. This was definitely a conversation I know I personally really enjoyed. And as Riley mentioned, we'll be distributing this throughout our networks, both social media, as well as also through our email and online platforms after this. And also, as we wrap up Digital Health Week officially now, we've had enough interest from folks that we want to carry forward another Digital Health Week next year. So we're excited to continue with some of this type of programming. And then also, finally, I'll end it with sort of a call to action, which is that as we talked about today, if there's one area where a lot of the tech industry can kind of contribute and get involved, it's exactly on this one as it relates to infrastructure and the importance of closing that digital divide. It's critical to things like healthcare, but a whole host of other critical services that people now increasingly rely on. So with that, thank you to our panelists. Thank you to our sponsors and supporters for the week. Just one final call out there. We have Otradi OBI, we have HIMSS, Link Oregon, the Israel Consulate General to the Pacific Northwest, and OCHIN. Thank you to everyone. Have a great rest of your day.
Thank you, Skip.